Thank you very much. It's a pleasure to be here again.
Well, it's great
Um,
to have you for a second time. So I'm looking
yeah,
forward to everything you have to say.
and I'm going to be careful to leave enough time for discussion so that we can make up for some of the time we missed on the last lecture as well.
Beautiful. I appreciate that very much.
Yeah.
Thanks.
Okay. All right. So Michael, I want to thank you. Special thanks to John Papadopoulos and to Steve Shore for organizing this conference, which is essential in getting health information out that otherwise is very difficult to access. And that's why I participate in this, because it's an opportunity to communicate serious issues about healthcare that are otherwise very difficult to put together. So with that as a preface, I got two excellent questions after the last lecture about the overall status of American healthcare. One was, what sources of information can we trust? And the other was, what can we do to protect our own life, our own health in this disordered healthcare context? And I want to address both of those issues by looking at what we know about statins and what you might want to do about the question of whether you want to take statins or not. So we'll use statins to answer those two questions. So let's start with a quick review from the last lecture. This is a slide that shows how difficult it is for doctors and patients as well to get accurate and complete information about healthcare and about drugs in particular. Here's a doctor out in his or her sailboat with scientific evidence. The doctor's got his or her black bag in case there's a house call to be made. And the doctor's looking up at the public information that is available to him or her, to them, we'll say. And that includes peer-reviewed medical journals, clinical practice guidelines, drug company marketing, public information on the media. And that is the totality of what doctors are relying upon as so-called scientific evidence to decide how to treat their patients. The truth is, the vast majority of the information is underwater. This in our iceberg, it's the part of the iceberg that's underwater and is not accessible to the doctors or the patients. And it's not accessible not because people don't work hard enough and not because people aren't smart enough. It's inaccessible because it's not available. The vast majority of this information is not available out of the context of litigation. And the 12 or 15 years that I spent in national pharmaceutical litigation, I had access to all of this information below the waterline. And my job as an expert was to explain to the court how the information, the actual information that the drug companies had in each particular situation differed from the information that was available to doctors. And that's what I'm going to talk about today in terms of statins. So down here we have the completed case report forms from patients. Every time a patient who's participating in the study goes for a scheduled visit, a piece of paper is filled out with their medical status and their lab results and x-rays or whatever. And this enormous volume of information is put into electronic data sets and then into clinical study reports. When a manuscript is submitted to a journal for publication, none of this, zero, is submitted with the manuscript itself. The manuscript is a summary, and usually the drug companies help to write up these summaries. But the manuscript is a summary of all this, and it's about 5 or 10 pages, sometimes 15, but it doesn't contain the depth of this information, and we don't know that it's complete. So that when a clinical trial is submitted to a journal, the only thing that's submitted is the manuscript itself and not access to this information underneath. So this poor doctor has been trained, browbeaten into believing that he or she is getting evidence-based medicine when the evidence really lies down here. And if our healthcare system is ever straightened out, it's going to be partly because this information becomes accessible to peer reviewers before they review the manuscripts, so that they can know that they're getting an accurate and complete representation of what actually happened in the study. The next slide that I want to show, and this I showed last time as well, is that this is a diagram or a cartoon of Plato's allegory of prisoners in the cave. And Plato's point was that these prisoners who are tied down inside this cave, and their only view of the external world is these shadows that are cast on the cave wall from the light behind the this barrier, and these let's call them prison workers are holding these figurines to cast the shadow on the wall that the prisoners accept as reality. And the prisoners are actually in the same position that you are in and that your doctors are in terms of trying to discern what the actual evidence from the clinical trials are, because the figurines here are analogous to the manuscripts that are submitted to the medical journals for publication. It's not reality they're looking at. It's a real condensation of reality. And finally, I want to remind you of this slide from Pfizer and the quote from Maya Angelou, who says, when people tell you who they are, believe them the first time. Pfizer, this is a slide from litigation, not litigation I was in, but Pfizer is talking about its ownership of clinical trial data, and it tells they tell who they are. Pfizer-sponsored studies belong to Pfizer, not to any individual. That means that they own and control the data. And they're very frank, brutally frank, about the purpose of their data is to support directly or indirectly marketing of their drugs, not improvement of Americans' health, not either from a point of view of efficacy or efficiency, not to improve population health. It's to market their drugs. That's their job. They do it well, and they're committed to it. And they go so far as to say, confirm that their primary goal is marketing of their drugs. They say, therefore, commercial and marketing medical officials within Pfizer, the marketing department within Pfizer, needs to be involved in all data dissemination efforts. With that as a preface, I want to focus these concepts now on statins and what we know about statins. So I'm going to start the talk, the timeline here, with the 2001 National Cholesterol Education Program Guidelines of 2001. Before 2001, the first statin was marketed in 1987, Mevacor. And the first studies that were done on statins were done on people who were at high risk, because if you want to show a drug is beneficial, you generally you want to do a study on a high-risk population so that you get a number of events, and you can do, it has the statistical power to show whether the drug is significantly beneficial. So before 2001, the general principle was that people who already had heart disease should be on a statin. And that had been confirmed by those initial studies. But the 2001 guidelines really opened things up to create the impression that it's necessary to treat many people, a large percentage of people who don't have heart disease, with statins. So, well, the Adult Treatment Panel 3, that's synonymous with the National Cholesterol Education Program Guidelines. Well, ATP3 maintains attention to intensive treatment of patients with coronary heart disease. Its major new feature is a focus on primary prevention in persons with multiple risk factors. Now, if we go back to Pfizer's honest statement about the purpose of their data is to support directly or indirectly marketing of our product, if you want to sell the most statins, it's not the population that already has heart disease that's your target. They're easy to sell to, and they're a minority of the adult population. What you want to target is healthy people. You want to create a knowledge environment that convinces doctors to treat healthy people with statins. That's where the action is. So in these guidelines of 2001, in their effort to broaden the population for which statins are recommended, the guidelines say in recent trials, statin therapy reduced the risk for coronary heart disease in men and women, in those with and without heart disease. That's a straightforward statement. There's nothing ambiguous about it. And they sent us to a table. And if we look at the table that gets to cholesterol management in women, which is on page, I think, 211 of this almost 300-page guideline, but ordinary docs and ordinary people are not going to get to page 211 of this guideline. I was writing my first book at the time when this came out, and so I did read the whole thing, and I found this statement on page 211, special considerations for cholesterol management in women. And they talk about the population to which the statin manufacturers would like to sell their statins. And these guidelines reflect their interest in broadening the population. So we're talking about women at moderate risk of heart disease. They have a 10 to 20% 10-year risk of heart disease, and their LDL's above 130. And this slide says, and this is absolutely gobsmacking, special considerations. Clinical trials of LDL lowering generally are lacking for this risk category. Generally are lacking. This is not evidence. And there was only one study that was included in these guidelines that addressed primary prevention for women without heart disease, and it did not show a significant benefit. And then they go on to say rationale for therapy is based on extrapolation of benefit for men of similar risk. Now that's a ridiculous proposition, and it's even more ridiculous that neither patients nor doctors were told about that. So when the guidelines came out in 2001 that tripled the number of primary prevention patients without heart disease, when that came out, people and doctors were not told that the evidence for women was, quote, generally lacking, which means not there. So that proposal tripled the number of people without heart disease for whom statins were recommended. Then we get to the 2004 update. And the 2004 update was based on 5 new trials, the results of which had come in after the 2001 guidelines were issued. So that makes sense to update the guidelines. And what the new guidelines recommended is for moderately high risk persons, 2 risk factors and a 10-year risk of 10 to 20%. The recommended LDL goal is 130 milligrams per deciliter, but an LDL threshold of 100 is a therapeutic option based on recent trial evidence. So what they're doing is they're taking the broader population of people without heart disease that had been addressed in 2001, and they're saying we want to broaden that population again so that we were talking about just people with LDL levels over 130 before, but now we're going to offer people with LDL levels above 100 statin therapy, which again is going to significantly increase the number of people. And of these 5 studies that had the results of which became available since the 2001 guidelines, there was only one study that addressed the effect of statins in women without heart disease. That was the ASCOT study here. and this is the hazard ratio for atorvastatin, which is Lipitor. The hazard ratio for atorvastatin treatment on primary endpoint, which is the development of cardiovascular disease, by subgroup. And you see there are many different subgroups here, one of which is women. So this is the only study, new study, that had come out since the 2001 guidelines that addressed primary prevention with a statin for women. And what did this study show? In women, the people who took atorvastatin, Lipitor, had a 5.9 per thousand incidence of cardiovascular disease, and the women who took the placebo had a 10% lower incidence of cardiovascular disease. Now, this was not statistically significant, but the fact that the people who did not take the statin had a 10% lower incidence of cardiovascular disease is hardly evidence that the threshold for treating women should be lowered from an LDL of 130 to an LDL of 100. So I was working with Meryl Guzner, a wonderful journalist who wrote the $800 million pill many years ago when I wrote my first book, and became director of Center for Science in the Public Interest. And we organized a letter that we sent to the National Heart, Lung, and Blood Institute. And we said in that letter that we had two problems. Number one is that the threshold for treating women was lowered. There was no evidence before, and there was even less evidence now in 2004, and that should be retracted. And that 8 out of the 9 experts who wrote these guidelines had financial ties to statin makers and did not declare their financial ties in the guidelines that were published, suggesting the LDL threshold be lowered to 100. So Meryl and I and 33 other experts, researchers, clinical experts, wrote a letter to the director of the National Heart, Lung, and Blood Institute and said these guidelines really need to be reconsidered. They're rife with financial conflicts of interest, and they're not based on evidence for women. And we got a letter back from Barbara Alving, who was the acting director of the National Heart, Lung, and Blood Institute. And she wrote that in the absence of specific clinical trial evidence about moderately high-risk women, so she's admitting that we're right, that there's not evidence to show that statins are beneficial for women without heart disease who have some risk factors. In the absence of specific clinical evidence, that there's an absence of evidence. She went on and said, for many women, now look at this, and it's going to tug on your heartstrings, but let's look at it on second look. Let's think about it objectively. For many women, the first sign of heart disease is sudden death. Sound public health policy demands that the significant risk for illness and death in women be addressed with science-based prevention recommendations. So, amen, that's right. Women had been largely ignored in the prevention of heart disease because heart disease occurs earlier in men and more frequently in men, and women certainly deserve the same quality of health care and prevention that men get. So she's saying, because the first sign of heart disease might be sudden death, let's take a cautious approach. A sound public health policy demands that the significant risk of illness and death in women be addressed with science-based prevention recommendations. Well, the problem is that there was no evidence that statins reduced the risk of death in women without heart disease, and there still isn't such evidence. So by making this claim that they're serving women by looking ahead into the science, it doesn't hold water. It's not disciplined thinking. It's not disciplined thinking. So Barbara Alving did agree that the conflicts of interest should be declared, and that those conflicts of interest were posted on the National Heart, Lung, and Blood Institute website, but I don't think they got out to the public very much. So Jim Wright and I, Jim Wright is a wonderful guy, and I hope you will tune in on Monday evening when Jim and I are going to have a conversation moderated by Steve Shore, I think. Jim Wright had been somewhat of a mentor to me as I made the transition from being a practicing family doc, albeit having done a 2-year fellowship in statistics and epidemiology. But I was a practicing doc, not an academic. I wasn't familiar with writing papers. I'd written a couple, but Jim was an academic, is an academic, a very smart guy and a wonderful guy. And he and I wrote a paper together that was published in The Lancet. The title of the paper was "Are Lipid Lowering Guidelines Evidence-Based?" And we have pooled the data from 8 randomized trials that compared statins with placebo in primary prevention populations at increased risk. This is the population for women that we were just talking about, and similar populations of men. Unfortunately, our analysis is imperfect because these trials are not solely primary prevention. 8.5% of the patients in these primary prevention studies already have evidence of occlusive vascular disease. Furthermore, many of the patients, in some studies, more than half of the patients, have a 10-year risk of heart disease over 20%. And though experts generally agree that if your 10-year risk is over 20%, you should be treated like somebody who already has heart disease, and you should be on statins. And there was, because the patient level data, as showed in that iceberg slide, because that patient level data is not submitted to the journals when the articles are published, it is not published. The studies that are published don't include the distribution of risk in the population being studied, so that when those studies are published, you can't tell how many people came into the study with more than a 20% 10-year risk. So not only are there people who already have cardiovascular disease, a significant portion of them have greater than 10-year risk, greater than 20% risk of developing heart disease over the next 10 years. We went on. Statins did not reduce total coronary heart disease events in 11,000 women in these primary prevention trials. Similarly, in 3,200 men and women older than 69, statins did not reduce total cardiovascular events. And finally, we wrote the CTT collaborators, and let me just take a minute to explain what the CTT is. That's cholesterol treatment trialist collaborators. And this is an organization that is run out of Oxford University. It is a nonprofit organization, though its parent organization takes a lot of money from drug companies for drug research. But the CTT collaborators made a Faustian bargain with the manufacturers of statins back in 1994. The bargain was that all the clinical trial data, all the information from below the waterline in our study of the doc looking for evidence, scientific evidence. The deal was all the data would be submitted on each of the major statin trials to the CTT, the cholesterol treatment trialist collaborators, and they would do meta-analyses, and they would show what all of the studies showed. So this is an effort by the manufacturers to pool their studies so that they have greater statistical power to determine whether or not statins are effective for lower risk groups, like women, like people with risk under 20% over 10 years or 10% over 10 years, and elderly people. Those are the primary groups of concern. But the CTT gets the data, and they do the meta-analyses on the data, but they won't release the data. And therefore, these so-called most authoritative meta-analyses about statins, because they're based on the primary patient data that's under the waterline, but it's not been vetted. They have the data, but they won't release it. And I'll talk about this a little more as we go on. So Jim and I wrote this paper, and I thought that the statin world would stop spinning on its axis, but nothing much happened until the 2011 Cochrane Review came out. Now, Cochrane Review has been the most prestigious and independent review organization, writing meta-analyses of the best data they can get. In 2011, the Cochrane Review updated its recommendations for statins for the primary prevention of cardiovascular disease. And in the conclusion of that review from 2011, they said this current systematic review highlights the shortcomings in the published trials of statins for primary prevention. Selective reporting and inclusion of people with cardiovascular disease in many of the trials included in previous reviews of their role in primary prevention, and that's what Jim Wright and I had written about in the Lancet a few years earlier, make the evidence impossible to disentangle without individual patient data. And the CGT were not releasing the individual patient data. So the Cochrane concludes this by saying caution should be taken in prescribing statins for primary prevention among people at low risk, cardiovascular risk. And that made perfect sense. And we need the data to know who's going to benefit and who's not going to benefit. However, in 2013, just 2 years later, the Cochrane Review did a 180-degree pivot. And they said 18 randomized controlled trials were included in the review. All-cause mortality was reduced by statins, as was combined fatal and non-fatal cardiovascular disease. And these recent findings from the cholesterol treatment trialist study that was published in 2012, recent findings from the CTT study using individual patient data meta-analysis indicate that these benefits are similar in people at lower risk, less than 1% per year risk of a major cardiovascular event. Now, this is really important. This idea that the CTT says that treating people with less than 10% 10-year risk of developing heart disease, people who don't currently have heart disease, benefit from taking statins. This is a radical expansion of the population for whom statins are shown to be effective. And CTT has made this recommendation. Remember, their data have not been presented for external review, and a radical change. So Cochrane goes on to say, why is this important? And they say the most recent systematic review, which is the CTT of 2012, using individual patient data from the majority of statin trials, provides strong evidence that benefits from statins outweigh any possible serious adverse events, even at very low levels of cardiovascular disease, meaning we're going to sell them to a very large population, low levels of CVD, cardiovascular disease event rates. These new findings counter earlier opinion that the evidence is insufficient to support the use of statins in primary prevention for women or in older men. And they attribute this position to the paper that Jim Wright and I wrote in 2007. So they're saying now we acknowledge this paper, though nobody had acknowledged it before in print. We acknowledge it, but we now have the 2012 CTT meta-analysis, which rebuts Abramson and Wright and shows that we need to radically expand the number of people for whom statins are recommended. Now, I was at a medical meeting just after this Cochrane review, days after this Cochrane review was issued. And Harriet Rosenberg, a wonderful woman, a medical anthropologist up in Canada at York University, came up to me and asked me if I was aware of the latest iteration of the Cochrane review recommendations, and I was not. And she said, well, they're calling for a revision of the guidelines to radically expand the number of people for whom statins are recommended. And they're relying on the 2012 CTT meta-analysis. And so I went back and I looked at the CTT meta-analysis and tried to think about it critically. And let me show you what the analysis says, and then I'll show you what came up, what the result of that critical review was. So this is the actual publication of the CTT's 2012 meta-analysis. Note that the title is the effects of lowering LDL cholesterol with statin therapy in people at low risk of vascular disease. So they're talking about this population that's at low risk and whether statins are going to work. Now, as we go through this, watch the shifting, the sort of magician's trick of getting you to look at something and look away from something else. Because the definition of low risk is changed throughout this meta-analysis, and it substantially changes what their findings mean. So they say, first of all, statins reduce LDL cholesterol and prevent vascular events, but their net effects in people at low risk of vascular events remains uncertain. And then we see that the reduction of LDL cholesterol with statins reduce the risk of major vascular events, largely irrespective of age, sex, and baseline LDL. And then they say, in participants without a history of vascular disease, statins reduce the risk of vascular and all-cause mortality. Powerful statement. And if we are as trusting of the authority in healthcare research and publication as we ought to be able to be trusting, that would be a compelling argument to broaden the population for whom statins are recommended to lower risk people. But notice that they've changed the definition of low risk from under 10% 10-year risk to in participants without a history of vascular disease. And what they've done is they know how many people without vascular disease have greater than a 20% 10-year risk. They're the only ones who know, because they're the only ones who have the primary data from all these studies. But they've done this sleight of hand trick where they changed from low risk people, less than 10% people who don't have a history of heart disease, to simply people who don't have a history of vascular disease. So they're including high risk people in this population that they're saying statins reduce the risk of death. And they're expanding, they're artificially inflating the benefit of statins for low risk people. And their interpretation is in individuals with five-year risk. Now, this is not a sleight of hand. In the UK, they talk about 5-year risk. We talk about 10-year risk. So for 5-year risk, you have to double the risk to get to 10-year risk. It's approximate, but it's conservative, because as people get older, as another 5 years go by, the risk actually increases. So if we just double the 5-year risk, we are being conservative about translating that into a 10-year risk. So they say in individuals with 5-year risk of major vascular events lower than 10%, which means 10-year risk lower than 20%, each millimole reduction of LDL cholesterol, and that means 40 points of 40 milligrams per deciliter of LDL, produced an absolute reduction in major vascular events of about 11 per 1,000 over 5 years. Now, they've taken the percentage here of 20% risk over 10 years, and they say it works there. But now they've shifted their definition again, because now they're including people in this group that already have heart disease. There are people who, secondary prevention people who have cardiovascular disease, who have less than a 20% 10-year risk. So in the first instance, they have given up the percentage risk and they go to who has vascular disease. And in the second instance, they go to the percentage, but they're willing to include people with vascular disease. So Jim and I and Harriet and Nick Jewell, who's a world-class statistician, got together, and we did a critical analysis of this 2012 meta-analysis, because we knew that the guidelines were going to be updated soon, and we wanted to get a rebuttal into the medical literature. I'm sorry, one thing, the meta-analysis, the 2012 meta-analysis concluded with the suggestion that the guidelines that your doctors follow should be revised to include these lower risk people. So Jim and Harriet Rosenberg and Nick Jewell and I we reanalyzed this data, and we had a paper published in the British Medical Journal. And our conclusions were that lifestyle factors, including lack of exercise, tobacco use, and unhealthy diet, account for about 80% of cardiovascular disease. 80%. So this is the headline of the story. If you want to prevent heart disease for yourself, your family, your loved ones, your parents, 80% of the risk is what you do about your own healthy habits. Now, for people at low risk of cardiovascular disease, and that's 10% risk over the next 5 years, because the British Medical Journal obviously is written in the UK, but if we go less than 20% risk over the next 10 years, statins do not reduce the overall risk of death or serious illness. I want to say that again. For people with less than a 20% risk of cardiovascular disease over the next 10 years, statins do not reduce the overall risk of death or serious illness. And in order to prevent one heart attack or stroke, and this is a non-fatal heart attack or stroke, because there's not a mortality benefit, in order to prevent one non-fatal heart attack or stroke, 140 people at low risk, less than 20% 10-year risk, must receive statins for 5 years. Now, this does not say, and I'll talk about this more, this does not say whether people should or should not take statins, but it tells you what your chances of benefiting by taking statins are. So 140 people must receive statins for 5 years in order to prevent one non-fatal cardiovascular event. And the side effects of statins include muscle symptoms, increased risk of diabetes, especially in women, liver inflammation, cataracts, decreased energy, sexual dysfunction, and exertional fatigue, and occur in approximately 20% of patients. Now, practicing docs use that number, cardiologists, 20%. We cited a study, a complicated study that was based on electronic medical record reviews, and we misinterpreted that study. And we said that study confirmed the impression that side effects occur in about 20% of people. That our mistake did not change at all the conclusion of our analysis, and we issued a correction because it was in fact a note. Now, as we approach here we go to the 2013 guidelines that have integrated the CTT's analysis and conclusion into the American College of Cardiology and American Heart Association updated guidelines for 2013. These guidelines came out a month after our paper was published in the British Medical Journal. We were accused of having inside information about the upcoming publication of the new guidelines. that we did not do that. We did not have an unfair advantage, but we did have an unfair advantage because Harriet Rosenberg was on our side. She participated in these efforts, and she figured out that the 2012 CTT meta-analysis would be used to expand the guidelines recommendations for treatment of low-risk people with statins. She figured out that that would happen. And lo and behold, it did happen. Here we have the issuance of the new guidelines, and what they did, what they changed is two large changes. They lowered the threshold, the risk threshold for starting people on statins from 10% to 7.5% 10-year risk, and they made it optional for 5% risk. So they expanded the population for whom statins are recommended greatly by lowering the threshold of risk. And they also abandoned the LDL threshold. So whereas before the LDL threshold had been you should treat if the LDL is above 130, and then in those 2004 update, in the 2004 update, they lowered that to an optional threshold of 100. They just got rid of the LDL threshold. They said that doesn't really matter. It's just the risk you have. So the bottom line is that these 2013 guidelines, compared to the 2001 guidelines, would increase the number of US adults receiving or eligible for statin therapy from 43 million to 56 million people. Most of the additional patients are people for whom statins are recommended, more than 2 million. Most of this increase in numbers, 10.4 million of 12.8 million. So they're recommending statins for an additional 10.4 million adults without cardiovascular disease. And among adults between 60 and 75 years without cardiovascular disease who are not receiving statin therapy, the percentage of people who would be eligible for such therapy would increase, listen to this, increase from 30% to 87% among men. This is people aged 60 to 75, and from 21% to 53% among women. So this is another enormous expansion of the people for whom statins are recommended. Now, Rory Collins, Professor Sir Rory Collins, is a leader of the CTT, and he didn't realize how radical a critique our BMJ article published in October of 2013 was. But in March of 2014, when this article was written in The Guardian, Professor Collins really raised a ruckus about our paper. And he said, or the article in The Guardian says, Professor Sir Rory Collins from Oxford University said he believes GPs and the public are being made unjustifiably suspicious of the drug, the statin, creating a situation that echoes the measles, mumps, and rubella vaccine controversy. Now, he's referring to our article, specifically to our article in the BMJ. And he says, it is a disservice to British and international medicine, he said, claiming that it was probably, our article was probably killing more people that had been harmed as a result of the paper on MMR vaccine by Andrew Wakefield. I would think the papers on statins, that would be the paper you see, including the paper that you just saw in BMJ. I would think the papers on statins are far worse in terms of the harm they've done. Now, that is leveling a pretty harsh accusation at us. And Sarah Bosley, who wrote the article, got in contact with me, told me what Rory Collins had said, and I responded to her with a little bit of pique, I must say. Abramson said the analysis by him and his team, it's not my team, it's my colleagues, published in the BMJ showed statins did not significantly reduce mortality in the 20 or 10% risk groups. This raises two issues, Abramson said. First, Collins is fear-mongering when he says that lives will be lost as a result of our calculations. Second, if Collins believes our analysis is not correct, and I'm speaking straight to Sir Rory Collins here, if Collins believes our analysis is not correct, then he should release the patient-level data so this discussion can be based on direct analysis of the data rather than relying upon their representations of the manufacturer's data. At this point, I believe there is no excuse for not making this data public, and the ongoing secrecy only raises the public's level of suspicion. Rory Collins responded by storming into the office of the editor of the British Medical Journal, who published the journal that published our article, and demanded retraction of our article. Demanded retraction. Fiona Godley, who was the editor and is a wonderful person and a clear thinker, she had been the editor for something around 10 years, responded to Professor Sir Rory Collins' demand by appointing a 6-member panel to adjudicate Collins' demand for retraction. She wanted to distance herself from this and have an independent panel determine whether the article should be retracted or not. And now this is hardball in the medical world. This was really stressful. Really stressful. And that we went through this, the 4 of us who wrote this article, that we went through Collins's frontal attack and spent some 6 months, 5 months in the uncertainty, not knowing whether we were going to be publicly disgraced. That was really stressful. And I must say, it discourages people from speaking out and doing this kind of critical research. But when the panel finally reached this decision, which was published August 15th of 2014, the editorial wrote, the panel was unanimous in its decision that the 2 articles, there was another article in the same issue of BMJ that made the same erroneous interpretation of the article that we did. As I said, it was very confusing. And Professor Collins demanded retraction of that article as well. The panel was unanimous in its decision that the 2 articles did not meet any of the criteria for retraction. The error did not compromise the principal arguments being made in either of the articles. These arguments involve interpretations of available evidence and were deemed to be within the range of reasonable opinion among those who were debating appropriate use of statins. So we were exonerated. Rory Collins ended up with egg on his face, but he has more access and control over the media than we do. And the failure of his attempt to have our article retracted didn't get too much attention, but it was covered by David Armstrong, who was a wonderful writer, first for the Wall Street Journal and then Business Week. And David Armstrong, I had worked with him on the Vioxx litigation, and I had worked with him on statins as well. And he's a great guy, a real honorable, hardworking journalist. And he wrote, I think, a bit tongue-in-cheek here, but as they say, revenge is best served cold. He wrote an article, the headline of which was Harvard researcher wins round in brawl over Oxford peer over benefits of cholesterol drugs. Now, I got to say, for David Armstrong to have a headline, brawl with Oxford peer, in other words, I'm a peer of Professor Sir Rory Collins, you have to appreciate the humor in it. And he wrote, the verdict is in on a bruising spat between big name researchers, and that's kind to me, at Harvard University and the University of Oxford over a paper questioning the value of prescribing cholesterol-lowering drugs to people at low risk of heart disease. The decision goes to Harvard. That's not great news for the pharmaceutical companies, that make the medications. Now, it didn't faze the drug companies one bit, unfortunately, because bad news about drugs doesn't travel very far, whereas good news, or news that that effectively neutralizes critics, travels very far very quickly. So a year after the BMJ editors wrote that editorial saying that the 6-panel commission decided that our papers did not warrant retraction, they had asked the CTT to provide the patient level data. They had said that we can't practice medicine this way, which is the argument that I've been trying to make in my lectures to you folks. And they wrote a follow-up editorial a year after the decision was made by the group not to retract the paper. In August 2014, an expert panel convened by the BMJ called for the anonymized individual patient data from the statin trials to be made available for independent scrutiny. Now, the anonymized individual patient level data, when you do patient level data, you cannot have it trackable back to individual patients. Individuals must have their privacy protected. So everyone agrees on that. Now, in terms of independent scrutiny, this is a point I was making in the lecture on Monday, that when drug companies, or the CTT in this case, submit an article that describes a clinical trial or a meta-analysis of clinical trials, the peer reviewers do not get access to the primary patient level data. So they cannot determine whether the manuscript accurately and reasonably completely presents the information from the trial. So the editors at the BMJ are saying we need to make this patient level data available for independent scrutiny. Our subsequent inquiries, guided by an expert advisory panel, have revealed the worrying extent to which these data remain hidden. And this is from 2014. And when I tell you in a lecture that peer reviewers don't get to see the actual data from clinical trials, it's shocking. And when I tell groups of doctors that the articles that they are trusting as scientific evidence, and they trust enough to take the information and treat their patients based on that information, that the peer reviewers didn't get the patient level data, they're nonplussed. They can't believe it because they've been taught that what's published in peer-reviewed journals is in fact scientific evidence. Whereas we're really in a situation where we're allowing the authority of the drug companies to decide what we get to see instead of making up our own mind about what the data say. Now, this is some, it just keeps getting crazier and crazier. The editors of the BMJ say we also wrote to the principal investigators of 32 major statin trials, 27 of which were included in the CTT analysis. Despite follow-up emails and phone calls over a year, only 7 of the 27 trialists who have studies that were included in CTT even responded. They don't say whether they gave their data or not, but only only 7 of those 27 researchers even took the time to respond to the request for the data. And the BMJ editors say in stark language here, listen to how strong they are, from 2015. The statin saga forces us to confront the deep flaws in our current system for evaluating medicines and guiding clinical decisions. Now, these are strong words, and the BMJ is a major journal. You would think that this would change things. In particular, how can it be right to recommend mass treatment of healthy people without independent review of patient-level data, especially the data on adverse effects? The statin trialists have huge potential the trialists who control this data, have huge potential, and they have a choice. They can take the lead on transparency, in other words, deliver their data, their patient level data to independent statistical analysis. They can take the lead on transparency or be pulled kicking and screaming into the light. Now, this is a fabulous editorial, strong, powerful, from a respected organization. Unfortunately, the last phrase is wrong. They were never dragged screaming, kicking and screaming into the light. They've never been dragged into the light. These data still remain, even now, the data remain confidential. Well, we'll do this. So in 2018, the American Heart Association and the American College of Cardiology updated their guidelines, and they said truthfully, unlike the CTT guidelines, they said truthfully that for patients greater than age 75, randomized controlled trial evidence for statin therapy is not strong. So clinical assessment of risk status in a clinician-patient risk discussion is needed for deciding whether to continue or initiate statin therapy. Now, this is really critical because when we talk about who should take a statin and who shouldn't take a statin, we're using language that is very authoritarian, patriarchal. We're telling people how they should evaluate the risks and benefits of taking statins. We're telling them how they should evaluate it. Instead of asking people, telling people that this is the chance you'll benefit, and this is the best guess we have about the chance of being harmed, and you have to make the decision about whether you want to take a statin, given the evidence of benefit and potential evidence of harm, even though we don't know exactly what the potential benefit is because the data aren't transparent. So when we talk about doctors and patients working together, that's critical. And I'm going to show you in the next slide how we can do that. It's critical, but we got to understand that the basic patient level data, the fundamental patient level data are not available for independent review. So, So this is a CTT meta-analysis from 2019 for people over age 70. Now, once again, they are trying to expand the population for whom statins are recommended. They're rebutting attempting to undo what the 2018 guidelines did, American College of Cardiology and American Heart Association guidelines did, by saying that evidence for efficacy over age 75 is scant. So if we look at people in the CTT database now who don't have vascular disease, and remember, many of these people are going to have greater than 20% 10-year risk, but they don't have vascular disease. And we look at folks age 70 to 75, we see that there's an incidence of 2.1 events. 2.1% of the folks have an event each year. 2.1% of the folks who took a statin have an event, and 2.4% of the patients who didn't take a statin or a higher dose of statin have an event in age 70 to 75. Now, it's hard to get a feel the pressure of those numbers. But if we do the arithmetic, it's not complicated, and we can go over it now or later or whatever. But we see 2.1% had an event in the treatment group and 2.4 in the non-treatment group. That means 0.3% fewer people have an event each year in the age 70 to 75 primary prevention group. And when you do the arithmetic, you get the number needed to treat. This is the critical number when you're talking to your doctors. This means how many people must be treated like these people, 70 to 75 without heart disease. How many of them must be treated for a year to prevent one episode? That's the number needed to treat. And when you do that arithmetic, when you see that it's 0.3%, that translates into you have to treat 333 people per year to prevent one non-fatal heart attack. And if we look at people over age 75, you have to treat 1,000 people per year to prevent one non-fatal heart attack. Now, those numbers, let me do the secondary prevention first, and we'll contrast those numbers. So these are people with cardiovascular disease. And we see that the difference here is a full 1% per year. And that means you have to treat 100 people per year, age 70 to 75, who already have heart disease. You have to treat 100 of them per year to prevent one cardiovascular event. And for people age 75 and older, you have to treat 125 people per year. Now, I practiced family medicine for about 25 years. And I would have many people ask me whether they should take a statin or not. And my response was, let's do the people with vascular disease first, because it's easier to think about. My response is that you have to treat about 100 of these people, age 70 and older, in order for one to benefit each year. And people would contemplate that. And if they asked me what I thought they should do, if they said, Doc, this is just too complicated for me, what do you think I should do? What would you do if you were in my situation? And it would be reasonable to decide either way. Either the odds aren't good enough that it's going to help me, I'm going to address the 80% of my risk, which has to do with living a healthy lifestyle, and let the statin issue go by the wayside. That's a responsible decision. Another responsible decision would be to say, hey, 1 in 100 isn't that good odds, but I may be the 100th person. And if they don't harm me, I think I'd like to try it. And then that person should go on the statin, be sensitive to the development of side effects, especially muscle symptoms that would make it more difficult for them to exercise, and give the statins a trial. And if they do fine, to stay on the statin. That's fine. Whichever decision a patient wants to make is fine. But what's not fine is telling somebody that they should be on a statin, because the guidelines say that, when there's only a 1 in 100 chance per year that they're going to benefit from. Now, the odds are a little bit slimmer in the people who don't already have vascular disease. You have to treat 330 people per year in age 70 to 75, and 1,000 people per year over age 75. And I think when the majority of people who understand those numbers are going to say, I'll pass on it, Doc. But it's not my decision, and it ought not to be guideline writers' decisions. It ought to be the patient's decision, your decision, about what your values show and how you want to prioritize your efforts to protect your health. Skip that. So then we get to 2024. I don't know how many of you heard this, but the way that those risk numbers are calculated, I've been saying less than 20% risk over 10 years, less than 10% risk over 10 years. The way those numbers are calculated are based on risk equations that are old. And epidemiologists looked at updated data from the National Health Survey. And they found that those risk equations actually approximately doubles the risk, the supposed risk that people have of developing heart disease over the next 10 years. So if the new risk equations are used to determine who should get a statin, about half of the people who take statins who don't have heart disease would no longer be recommended for statin therapy. This is a real blow to the statin industry. And for those of you who follow these issues closely, you might be thinking, well, what's the big deal about statins? Because they're all generic now. And the manufacturers of statins aren't making very much money from statins, because when drugs go generic, there is actually a working market, and the price goes down to the point where generic manufacturers can manufacture, distribute, and sell the generics and make a profit. And that becomes the floor, not an artificial price that's set by a drug company. So that market works well. The original manufacturers of the statins aren't making any money from statins anymore. So what's the big hullabaloo now that the manufacturers aren't pushing this? Well, this what I've told you so far, I stand on as objective analysis of the scientific data. But what I'm going to say now is my opinion, and I want to make that clear. But I think what's going on now with this further attempt, you'll see in a minute, to expand the population or maintain the population of people taking statins based on these new risk equations. I think what's going on is that statins have entered a new phase, and they're now a gateway drug into the much more expensive new biotech cholesterol lowering drugs called PCSK9 inhibitors. And instead of costing $100 a year, they cost about $7,000 a year. And the PCSK9 inhibitors lower cholesterol far more powerfully than statins do. And they're also maybe tolerated by people who feel that they don't tolerate statins. So that in order to sell the PCSK9 inhibitors, you've got to get people to go through the statins, either not lowering their LDL enough or not tolerating them, to get to the PCSK9 inhibitors. But you can't sell PCSK9 inhibitors, which are very profitable, unless people are first on statins. And my opinion is that that's what this latest example to expand statin use or maintain statin use in the population is. Now, let's see. Okay, so I'm gonna skip the background, and if we have to go back and review it, but I don't want to repeat. There was a claim made in the Journal of the American Medical Association articles that explained that the risk equations are doubling the number of people for whom statins are recommended, artificially doubling the number of people for whom statins are recommended, and that only half as many people should be on statins. The claim was made that if we take all those people off statins who no longer qualify by the old guidelines, we're going to have a lot of heart attacks caused. The evidence, it comes from the CTT's meta-analyses. It doesn't come from transparent, independently analyzed science. But because of this claim that there would be more heart attacks, the recommendation was made in this issue of JAMA that the threshold for starting people on statins based on their risk calculated by the new risk equations should be lowered from 7.5% down to 3 to 5%. And this is enormously low risk. This would put virtually everybody on a statin. And that was published in JAMA, in one article of JAMA, one issue of JAMA, that the risk equations need to be revised and that we should consider revising the guidelines. And this is reminiscent of the round of point and counterpoint that I described in 2013, when the Cochrane Review said we should revise the guidelines based on the 2012 CTT meta-analysis. This is very reminiscent of that. So Marianne Damasi, who's an independent journalist, PhD in science, in Australia, and got in touch with Rita Redberg, who has stepped down but was the editor of JAMA Internal Medicine for many years and is a professor of cardiology at the University of California in San Francisco. She got in touch with Rita and with me about writing a letter to JAMA critiquing this recommendation to lower the threshold for treating people with statins to 3 to 5%, because it sounds like it's going to get integrated into the new guidelines. We're in the same relative position that we were in when Harriet Rosenberg pulled me aside at the meeting and said, do you know what the Cochrane Review did? So we wrote this letter to JAMA. We wrote it in August when the initial papers came out, and it was not published until February 12th, 2 months ago, February 12th, 2025. So this is now stale news, and our letter is going to have very little effect, I think, on how people think about this. But let me read it to you because it covers what we think is going on. So, to the editor, recent study reported that utilizing the predicting risk of cardiovascular disease events, the PREVENT equations, developed by the American Heart Association and the American College of Cardiology for calculating cardiovascular risk, would lead to millions fewer US residents at low risk of heart disease being recommended for statins. Dr. Dio, who wrote one of the articles in JAMA that made this recommendation, Dr. Dio and colleagues reported that the PREVENT equations would reclassify 53% of US residents to a lower category of cardiovascular risk, estimating that 14 million fewer Americans would be recommended statins. This is essentially undoing what the 2013 guidelines did, resulting in, and this is based on CTT calculations, not independently vetted calculations, resulting in 77,000 additional cases of myocardial infarctions and strokes over the next decade. And by the way, they also said that it would lead to about, I think it's 55,000 new cases of diabetes, fewer cases of diabetes over the next decade, because statins do increase the risk of diabetes. So there's a counterbalance, but we left that out of our letter because that's not really what we're arguing about. This finding spurred calls to lower the current predictive risk threshold for initiating statin therapy. Currently, the 2013 guidelines recommend statins for adults with greater than 7.5% 10-year risk, with 5% optional, which was lowered from 10% in the previous guidelines. Now, Doctors Kahn and Lloyd Jones, in a Viewpoint article that was in the same issue of JAMA as Dr. Dio's article, talking about the difference in the percentage of people for whom statins are recommended based on the updated risk equations. Now, Doctors Kahn and Lloyd Jones suggest that the threshold of risk ought to be lowered again. 3 to 5% may now be reasonable. However, we disagree. There's no evidence that lowering the threshold to 3 or 5% would be beneficial. The calculation of 77% additional cases of 77,000 additional cases of myocardial infarction and strokes over the next decade by Dr. Dio and colleagues relied on meta-analyses, including the CTT meta-analysis of 2012, which we critiqued in the BMJ article in 2013, that was for which retraction was demanded but denied. However, the recalculation of the CTT 2012 analysis reported, that's our recalculation, that reported that statin therapy prevents one serious cardiovascular event for 140 low-risk people, 5-year risk less than 10% treated for 5 years. And statins for people with less than 10% 10-year risk resulted in neither statistical nor numerical reduction in all-cause mortality. Furthermore, statin therapy in low-risk people does not reduce all-cause mortality or serious illness. We are concerned that lowering the risk threshold will only lead to millions of more healthy people being recommended for statin therapy, but it may not help them feel better or live longer. Now, the reason why we wrote this letter and why I'm going over it in detail here in this lecture is because you folks are going to get confronted, I believe. That's what my crystal ball says. I don't know it for a fact, but I believe you're going to get confronted with new recommendations from your doctor to take statins if your risk is as low as 3 or 5% over the next 10 years. So we conclude by saying there also may be unintended consequences of widespread statin use in healthy people. For example, a 2014 study reported that people taking statins were more likely to have increased caloric and fat intake and body mass index over time than people who do not use statins. And the rationale or the thinking of why people may become adopt higher risk lifestyle habits, when they take the statins, they think they're protected. But the statins can offset at best only a small amount of the risk of going to a lower, less healthy lifestyle. And that's a key point in this lecture, is taking a statin doesn't protect you as much as living a healthy lifestyle. And even if it does provide you significant protection, it's not nearly as much as adopting a healthy lifestyle. So when you go to your doctor, or when your doctor says to you, let's talk about statins, remember, the goal is not to lower cholesterol. The goal is to prevent heart disease and have a happier and healthier life. So the question is not whether it will lower, statins will lower your cholesterol. They will lower your cholesterol. The question is, will they improve your health? And then finally, and this was my contribution, which I insisted on leaving in the letter, and it was left in the letter. Additionally, the results published in meta-analyses of statin trials are foundational to this discussion, but the CTT hold the patient level data and will not release them without all of the trialists' permission. Each and every one of the trialists must agree to release the data before the CTT can release the data. The data remains secret, casting a large cloud over the entire enterprise. So where are we left? I repeat, and I cannot say it enough, most of your future health is in your control. Now, that is not so much true for people at the lower end of the socioeconomic spectrum. I assume that most of the people who have the wherewithal and the interest to watch this lecture have the ability to take control of their health habits. And don't get seduced by all the talk about the latest guidelines and the latest technology and the PCSK9 inhibitors and all that stuff. Don't get seduced into thinking that that is the way to maintain your cardiovascular health. But by far the best way to maintain your cardiovascular health is to do the things that we know will be helpful. Don't smoke, exercise regularly, eat a healthy Mediterranean style diet. If you're under stress, get help. If you're not sleeping well, get help. These are the basics of protecting your health in general and your cardiovascular health. Number two, when deciding about starting a new therapy, always consider the number needed to treat. Now, if the guidelines get revised and you have a doctor who is telling you that you should be on a statin, you want to ask that doctor, what is the number, how many people do you need to treat with a statin for a year or 5 years, whatever date range your data for? How many people must be treated in order for one to benefit? That's the ultimate statistic that you need to know in order to then integrate that into your own personal values to decide whether a statin is right for you, not whether guideline writers tell you you should take a statin. That is a preposterous position. The question that came up at the end of the last lecture is, I showed a couple of FDA labels about that from which I could calculate the number needed to treat, and was asked, where can you get really reliable information? And that's an important question. And it really is two questions in one. Number one, the FDA label has the most reliable data. They have the primary data from the studies, though they won't release it, but they have to agree with the manufacturers how the data from the important clinical trials that they have sponsored, what they show about the benefit that you will receive from taking the drug or not taking the drug. They have those numbers, and it's the ultimate authority, not a tangential authority, on what your chance of benefiting from therapy is. Now, for the statins, it doesn't quite work because the authoritative source is the cholesterol treatment trialists numbers, and those numbers, if they were accurate, would span all statins, not just a particular statin. And so that the label for each statin does not contain that data. And it's not transparent anyway. And finally, transparency of clinical data is absolutely necessary for both doctors and patients to make rational decisions. In the 1660s, the Royal Society of London, with the physicist Robert Boyle and philosopher John Locke, and Isaac Newton, and they were in the Enlightenment Revolution, at the beginning of the Enlightenment Revolution in science. Boyle figured out the equations that talk about the force that's generated when water is heated, turned into steam, and creates a pressure. And that was what quickly led to the steam engine and the Industrial Revolution. Well, these scientists and philosophers got together and formed the Royal Society of London. And they adopted the saying, nullius in verba. Take nobody's word for it. Take nobody's word for it. Science must be transparent. This is in the 1660s, they did this. And the authority that they were confronting was the authority of the church and the Inquisition. Galileo, only 30 years before the Royal Society formed up, Galileo, using the telescope, concluded that the earth is not the center of the universe, and was convicted by the Inquisition to life imprisonment, which was then lessened to life imprisonment for home confinement. But just 30 years before the Enlightenment, philosophers adopted the saying nullius in verba, which includes don't take the church's word for it. Now we're in a situation where we're going back behind the 1660s in terms of the transparency of scientific data, and the authority that we confront that blocks us from getting that data is not the church, it's the corporate, it's the marketplace that is primarily directed by the pharmaceutical manufacturers and the healthcare corporations. So the authority that we confront is the marketplace, the financial marketplace, that largely controls what we think is medical knowledge, controls the generation, the creation of this knowledge, that controls the data that describes this knowledge, and controls the communication of this information in public. It's the financial markets, the incentives of capitalism. And I'm not against capitalism. It's a great way to create innovation and run a society. But in a capitalist society where that financial incentive is a driving force to progress, you must have guardrails on the integrity of the information. The public is not served to, when it has fantastic new biotech discovery, which we have, when there aren't guardrails on these discoveries and the dissemination of the information about these discoveries that ensures that doctors and the public get accurate information about the benefits and risks and cost effectiveness of these discoveries. So we need transparency, and it's a standard that was established almost 350 years ago. And we in modern medicine have gone backwards into the pre-Enlightenment era. So take care of yourselves. It's essential. You've got to understand the limits of the information that your doctors rely on and that you rely on. And common sense is ought not ever to be trumped by this so-called scientific information. And on that, I conclude my lecture. I do want to put in a pitch, two pitches actually. One is to send this lecture out to your friends, because this information does not disseminate through the conventional markets. The media doesn't want to know about this. They want to collect the money for their drug ads, and it's almost impossible to get this information out. So I thank you for listening. Please disseminate this information. And also one more pitch. My mentor and friend and hugely respected colleague, Jim Wright, is going to join me for a conversation on Monday evening here. I think Steve Shore is going to moderate that. And I invite you all to listen to this. Jim is a wonderful guy, brilliant guy with a really dry sense of humor, and I invite you to join us.
Great. Dr. Abramson, thank you so much. Definitely you present the information so clearly.
Thanks.
And you've inspired me for the first time to consider getting a tattoo, which is
Ah,
nullius inverva.
yeah. Great, great. Maybe I'll get one too.
Yeah. All right,
Where
maybe
should we,
we can go
what body
together.
part should we get it on?
I don't know. I got to build up my bicep to make it look good if I get it over there. But I think that is probably the mantra of my life. So, um, how can we trust even these companies? So how can we trust that these companies, if we make it so that they have to show us the clinical trial data, that they won't doctor up the clinical trial data, the clinical trial data?
That's a, yeah, that's an excellent question. So I was in litigation for 12, 15 years, national litigation, the big national cases. In that litigation, I had access to all the documents. We literally had access to the corporate hard drives, to the scientists' hard drives, to the marketing people's hard drives, and to the executives' hard drives. And there were occasional incidences, but they're rare, when the data that was put together misrepresented the actual facts. So people don't mess around with that. They don't mess around with the data. They have to send all this data to the FDA. And that's a pretty bad violation if they send erroneous data to the FDA. So yes, it's a concern, but it'll be 1,000 times better than, you'd have to be there through every patient encounter in the entire trial to assure that there was no monkeying around. But it is almost foolproof way to make sure that we could get the truth. And I don't think I stressed enough, Michael, that this data, it's not just enough to make it available, because ordinary folks and ordinary doctors, and even the most hardworking, disciplined doctors, aren't able to take this data and do an independent analysis. It's months worth of work for a non-expert person. But what needs to happen is that when the manuscripts are submitted to the journals, the 10-page manuscript that summarizes the study, before that manuscript goes to peer review, it should go to an independent statistician that has access to all of the patient level data. And that statistician should do what I was doing in litigation, should go through all that data and to see if the endpoints that were pre-identified were upheld, if the statistical analysis plan was upheld, if the dates of the trial were kept, and make sure that all of that makes sense before it goes to the peer reviewers. The peer reviewers can't do that, but it's not peer review. We assume peer review means that the data have been independently vetted and you can trust it. It's peer reviewed in the New England Journal. I mean, that's all doctors care about is the next sentence. But the peer reviewers can't do that. They need an independent statistical analysis to do it. And it's just crazy that our system doesn't require that. It's a demonstration. It's not crazy. It's a demonstration of the power of the drug companies in our society, that our politicians and scientists and researchers allow this situation to go on. It's going to take the people rising and making this an issue, and it's going to take doctors realizing that they can't provide the services to their patients that they claim to. They can't act as learned intermediaries if the peer reviewers don't have an independent statistical analysis of the study before it's peer reviewed. So that's what it's going to take.
So, now that I have my new tattoo and I don't really trust the words of anybody, I'd be scared that that an independent statistician would be, as susceptible to corruption as the credit rating agencies were. back in the in 2008 crash, for example. Is there anything, given that the data is anonymized, could the data just be made public? Like, why is that have to
Yes,
be?
it could be made public, and occasionally it is made public after the articles are published. The key, Michael, is that once an article is published and it comes to a conclusion that fits the criteria that doctors have been taught is forms the basis of scientific evidence. Once that happens, the horses are out of the barn. You cannot recapture that. When doctors, I was a practicing doc. I know what it feels like to be on the line. I know what it feels like to have inadequate information. And once doctors adopt a fact as information, people with a 6% 10-year risk of cardiovascular disease should be on a statin. Once a doctor adopts a fact like that and integrates it into his or her practice, in other words, does things to other people's bodies based on their belief about the quality of the evidence, once they do that, it is very hard to get them to revise their impression. So once the article is published, you can't put that genie back in the bottle. It's got to be before the article is published.
Okay. And well, do you see that with technology at the way that it is, that doctors could go in and actually kind of pull the latest information on something? Like, when as they're writing up a prescription, it could instantly say, this is the latest if this person's at this, or you could put in someone's blood work and it would say it would automatically update it, taking out the bias that the doctors have from previously seeing those publications.
That would be a great idea if the information that the AI has access to were independently vetted and true. It's not.
Right.
I use AI a lot now. It's a very powerful tool. And when I'm researching an issue that I want to take a deep dive on, I will use AI. But AI is stupid. It can't evaluate what it reads. It can tell you what I use it to find out what's out there. I don't trust its ability to evaluate, and it certainly can't think critically. So if the quality of the knowledge doesn't improve, AI is just going to give you more sophisticated and voluminous garbage. It's garbage in, garbage out.
Yeah.
Now, if you want to find out, ask a question like, what's the history of cholesterol guidelines? It's fabulous for that. It'll say in 2001, they say this, and four, in 2013, and 2018. It can get you that kind of information, but it cannot think critically. And I think that the best prediction that I can make about AI is it's going to increase the current power structures grip on what public knowledge is and even professional knowledge. It's going to increase their grip, not liberate people to get better information. We've got to deal. There is no way around dealing with the issue that peer reviewers don't have access to analysis of patient level data, that you cannot make that issue go away except in litigation. And I said, that's where I got my education. That's why I know this is so important, because my job was to go find the stuff in the secret documents that showed the lie of what was being used to market the drugs. And you just can't get around that.
No, and I agree, and I appreciate your skepticism with regard to what will happen with technology and who will actually be working on behalf of. So a couple of points. So just for people who are asking how to forward the lecture, I have asked John Papadopoulos, the man who makes all the magic happen in the back. If that's possible, I don't know that it is, but we will put it in the chat if it is or if it's not possible on how to share this lecture at this time. It will be possible in the future to share it. I'm just not sure when. And now I also have a question that someone asked me. This is on a personal note, Doctor, which is, are you wary of retribution from the medical establishment on speaking out like this?
The first answer, if you're asking me, I don't care.
Okay.
I'm 76. I did throw caution to the wind in 2002. I left my practice. I had a very nice practice. I was chair of family medicine at Lady Clinic and a lecturer at Harvard Medical School in healthcare policy, or in primary care at that point. I left that practice because I understood how much the journals, in this case, it was the New England Journal and the drug Vioxx, were being misled by the drug companies, and that it was a national emergency. And instead of taking care of patients one at a time, I realized I had these skills from my Robert Wood Johnson Fellowship, and I had this interest, and I was in a fairly unique position, not totally unique, but fairly unique position to take a deep dive into these issues and to bring them to the public. At that point, I was worried. I had my financial future wasn't secure, and it was a real risk. And I think the reason why I got away with publishing my first book, Overdosed America, in 2004, was that in the Harvard community, family docs are not held in very high prestige. They're thought to be some kind of inferior species of doctor. And I think the presumption was, as I didn't keep it a secret that I was writing this book, the Overdosed America, the first book. I didn't keep it a secret, but I don't think anyone took me seriously, because how could a family doc make a serious argument? And it was published, and then a week after it was published, Vioxx, which was a deadly drug, it killed about 50,000 Americans, claimed to be safer, it was far more dangerous, claimed to be better, it was no better than over-the-counter drugs. I wrote about that extensively, and the New England Journal's complicity in propagating inaccurate information about it. A week after the book was published, Vioxx was pulled from the market because another study came out and showed that it's dangerous. And the study that I had written about was, it was out in the public. It wasn't hugely influential, but Merck knew it couldn't get away with this anymore, and they pulled the drug. And then it was like I was shot out of a cannon. I was called by the publicist at HarperCollins, and she said, the limousine's going to pick you up in 50 minutes. You're going to do 3 national satellite TV shows out of Boston, fly to New York and do the Today Show and another morning show. And so I went from being a very implausible critic to being in the public limelight very quickly. And there wasn't time to shut me down. And then I started working with the FBI and the Department of Justice. And so they missed their opportunity to shut it down or for me to be at risk. And I was just lucky to have been able to go through that slightly open gate to tell the story.
Well, I appreciate your bravery on this. So once doctors learn that some of the things in the standard of care may not be factually accurate, what's to tell them how to modify their care? Because we're it's like when you're teaching somebody how to eat and but you focus on what not to eat, they're gonna fail because they don't know what to eat after that. What's your vision for how that would work?
This is a real conundrum. And the first part of the answer is that doctors and patients need to organize together to talk about the critical emergency of not having access to real data, that we can't practice medicine this way. And it's got to become a political movement. It's not going to change any other way. Now, when I was practicing medicine, I stopped in 2002. I had got the drift that statins were being over-recommended, and that the guidelines, I practiced for maybe a year after those 2001 guidelines came out. And I was studying them and had a critical perspective on them while I was taking care of patients. And what I would do would be to tell patients what the guidelines recommended, and then to tell them what I thought was the best scientific evidence and that they should make the decision. But if they were not going to follow the guidelines recommendation, I would actually ask patients to sign the chart. That's when we had paper charts. I would ask them to sign the chart because if, based on a discussion that I had with a patient, the patient had developed a heart attack, I would be held responsible for advising going against the guidelines. So I would have the discussion with the patient and then have the patient sign a statement in where the patient said, I understand the guidelines recommend statins, and I have made the choice not to go on the statins. And I think that's the best way you can do it. Now, what do doctors do about getting adequate information? That's a separate problem. And it's everywhere. It's that Paxlovid, Pfizer's studies show that Paxlovid only works for about 2% of Americans who are unvaccinated or have never had COVID. Yet the recommendations are to get the boosters. Excuse me, to take Paxlovid within 5 days of getting COVID, or the boosters are not supported by randomized controlled trials. They're supported by increased antibody levels, sometimes in mice, and we don't know how much those increased antibody levels correlate with a decrease in the risk of serious disease. These are things we just don't know. And when I'm talking to friends and when I'm lecturing, I tell them what is known and what isn't known. And I say, you got to make the decision. You got to make the decision. I can't make it for you.
I may have to take over that panel to ask Steve on Monday because I have so many questions for you and I just never seem to have enough time. So I will I might see you on Monday.
Yeah.
So who do the statins work for? Like who are they effective for?
Well, they work in terms of lower cholesterol on everybody who takes them, or almost everybody who takes them. That's not the issue. The issue is how many people do you have to treat in a certain category? How many people who already have heart disease, who aren't over age 75 or 70, how many do you have to treat in order for one to benefit? And the answer to that, as best we can tell, but we're trusting that the CTT is basically telling us the truth, but based on their numbers. So this is a ceiling of efficacy. You have to treat about 33 people who have heart disease for 5 years in order to prevent one heart attack or stroke. You have to treat 33 people. So a patient comes to me and says, and has heart disease, and says, should I take a statin? And I tell them, well, first of all, if you want to prevent heart disease, which I think is your real goal, let's make sure your lifestyle is in shape. And if it's not, let's get you help to get it in shape. And then there's a 1 out of 33 chance that the statin will benefit you over 5 years. And I can't tell you whether those numbers should dictate whether you should or shouldn't take a statin. You have to decide that. I can't tell you what color car you should buy. You have to decide that. It's based on your values. Does that make sense? Am I?
No, 100%. So it's not like, you give them to somebody and, they just prevented them from having a 50-50 chance of having a heart attack in the next year type of thing.
Yeah.
It's at a number, regardless of what group they're in, that leaves room for a person to have to make a personal decision on whether or not the risks outweigh the benefits.
Yes. So the best risk is 33 people for 5 years to prevent a heart attack and 80 people for 5 years to prevent a cardiovascular death.
Okay, wow.
So a person's response is not obvious to me. It depends on how they feel about those numbers. A 1 out of 80 chance of not dying of heart disease is a good thing. 5 years is a long time, but somebody's going to be the 80th person. So people have to decide that for themselves.
No, I see a lot of people who like to, who think they're taking care of their health by taking their drugs, right? By taking pharmaceuticals. And my mom being one of them, she'd always say, "Oh, look, I take my meds." And I said, "Well, I'm being healthy." And I'd say to her, "If you're being healthy, you wouldn't need to take those meds, right?" And
Well, that's not 100% true.
well, with regard, this was like she was eating a diet that caused her to have acid reflux.
Yeah,
So
yeah,
so that's what it was in context of. But go ahead.
yeah,
Sorry.
yeah. But I would say to your mom that the key here is not taking your meds, that knocking your cholesterol, lowering your cholesterol by taking a statin does not, it does not core, it does not mean you're going to be healthier. Living a healthy lifestyle is at looking at the most optimistic view of statins. Living a healthy lifestyle is about 4 times more important than taking a statin. So I would tell your mom that if she is committed to taking the statin to optimize her health, she should be 4 times more committed to living a healthy lifestyle.
Agreed. So I'm getting asked from an audience member about the risk of going off statins for someone who has a stent from 100% blockage event. And just keep in mind that this is not advice that consult your doctor, but what's your thoughts?
My thoughts are that you need to consider that. That's in the secondary prevention, maybe a little higher up in the secondary prevention category. And there is a finite chance that the statin can help. It's certainly less than 50-50. It's somewhere around 30. Uh, Maybe it's 20, 1 out of 20 people over 5 years, somewhere in there, between 10 and 30 people over 5 years, I would say. And you've got to make that decision. Do you want to take that risk? It's a hard decision. And the docs are reluctant to participate in that decision because they've got the electronic medical records. And if somebody who has heart disease isn't on a statin, they're going to get dinged for bad quality of care. But on that one, I would say do talk to your doctor. You may have to educate your doctor. You may want to get your doctor I think it's the third chapter in my book, Sickening, my current book, is all about it's all about this lecture, and it will educate you, the doctor, about the benefits of statins. In fact, my cardiologist went through my whole book, but especially the statin chapter, twice to make sure that I hadn't made any mistakes. Yet he feels pressure to have his patients follow the guidelines, even though we have a great relationship. He looked for errors in what I was saying and couldn't find them, couldn't find any. But it's got to be a negotiation with your doctor. And if you like your doctor, have mercy. The doctor's in a tough position here because he or she is being told that you should be on a statin, and he or his or her records are being overseen for so-called quality, which means conformity with the guidelines. And it's a way that the power structure can dictate how we practice medicine, but it's real. We have to live in this world. So be prepared to negotiate with your doc, and maybe it's not all or nothing. Maybe you talk about taking the dose down. But you've got to work with your doctor, and you may have to educate your doctor. And again, chapter 3 of Sickening will educate your doctor.
Great. I don't know if you're familiar with Dr. Kim Williams. He is he was I think the president of the American College of Cardiacs or Cardiac College. I forget exactly what it was. And
American College of Cardiology.
there you go. Yes, he was the president a number of years ago. He's plant-based and he's spoken at the Real Truth About Health conference. And T. Colin Campbell, who is you're familiar with his work? He's a nutritional, everyone seems to know him. He's a
Yeah.
nutritional biochemist. And years ago, they were on a panel together and got into a disagreement about the efficacy of statins. And and throughout the conference, when you listen to all of the different professionals and doctors and experts, you'll hear some conflicting information. It gets very confusing. And I always pondered on why they had such a disagreement. And your talk really sheds a light on it, which, in my opinion, I want to get your thoughts on this, which is T. Colin Campbell is actually doing the research himself. He sees it in a lab. It is unadulterated. He's seeing it with his own eyes, whereas someone like Dr. Kim Williams, who has all of the best intentions in mind, he promotes a plant-based diet. He lives it. He fights for medical equity, and and yet he comes to a drastically different conclusion, saying that no, the research shows that statins are effective. What are your thoughts on that it's one is seeing it directly and one is seeing it through the lens of a adulterated system?
I think you've got to roll up your shirt sleeve and show the tattoo on your biceps that says, take nobody's word for it. The most informative study that I know of, which is really mind-boggling, the Leon Diet Heart Study, randomized controlled trial that took people who had their first heart attack and randomized them to eat a Mediterranean diet, Mediterranean style diet, or a conventional post-heart attack style diet. And the mortality rate was far lower in the people who ate the Mediterranean style diet than the conventional diet, but their cholesterols didn't change. Their cholesterols didn't change, but the diet, the eating the Mediterranean style diet lowered their risk of death from heart disease. So that's the best answer I know. You can't answer the question. I mean, it's ridiculous for us to be talking in 2025 about what the data that the CTT hold might show. Most of it was collected by 2010, and they're just holding it against the public interest. It's nuts that this is going on. That's what the BMJ, that's the outrage that the BMJ editors were expressing in 2015. It's crazy that we have a mass therapy program and the answers are known. That the doc who was president of the American College of Cardiology could know the answer if that data were liberated, and it's not liberated. And doctors don't understand this. If they understood it, they would say, we're going on strike. We can't take care of people. We can't write prescriptions if we don't know what the real data are. And we can't get this information out. That's why conferences like this are so important, to get around the limitations and the censorship, the functional censorship in the media. We've got to get these discussions out. I don't know, maybe you could talk to Steve about posting these lectures earlier so people who are listening now, who understand what's going on and what an urgent situation this is, maybe get this situation, going viral. But it's going to be the control rods are going to get put into the reactor and stop the reaction rather than having a chain reaction go on. And in order for this to get fixed, there's got to be a chain reaction of people who understand that the data are captive, and doctors can't really practice as learned intermediaries.
So, well, regarding when this will be available, I think it would normally be available sometime around August, the lecture. We'll see if we can make it, although we have our own, schedule and processing, and there's 85 lectures and all this stuff to have to process through. I really can't say anything to it becoming earlier, but if you want to reach out to Steve also, you can reach out to Steve and see if we can make this a priority. And everyone will receive an email that's registered that it has come out. So once you get it, regardless of whether it's now or when, you can go ahead and share it at that time. So I've been reading T. Colin Campbell's latest book, which is a few years old, called the Future of Nutrition, and in it he talks about cholesterol, and he talks about something very similar, where and the way that he puts it is that cholesterol is really a benchmark for animal protein. And he says animal protein is the real problem, right? This is what his research shows. And that when you're lowering the cholesterol, you're just lowering the benchmark, and with the statins, but you're not actually producing health, because you're eating the wrong foods in general, and all the problems with the food are still there. What are your thoughts on that? And that'll be your final statement because we're about to be out of time.
Yeah, I think that's correct. I mean, it's just like the Leon Diet Heart Study. It's a marker, but it's very hard to lower your cholesterol significantly by changing your diet. And I think T. Colin Campbell would say that the health benefits of eating a plant-based diet are not mediated through cholesterol, they're mediated through other things.
Yes.
So there's nothing that he says that I disagree with. People may adopt it all or in part. But remember that I used to joke when I was practicing that I wanted to hand out T-shirts that said, "He or she who dies with the lowest cholesterol doesn't win." They've gotten in our heads that cholesterol is the measure of our future health and our quality of life and our goodness as a person. And it's just because there are drugs that they can make money on that lower cholesterol.
Great. Well, let me know when you want to get that tattoo, and
Okay.
I really appreciate it. And I may see you on Monday, not sure just yet. So thank
Okay,
you so much
good.
for all the information that you shared. It's always wonderful to hear you speak and to have the honor to be able to ask you questions. If we can unmute the audience, please, so they can share their appreciation.
Thank you.
Thank you.
Yes,
So
beautiful.
much,
Thank you.
Abramson.
Thank you.
Wonderful.
Dr.
Like you
Abramson.
said,
Thank you,
best.
Dr.